Thank you for that great presentation, Dr. Corvo. We are now excited to welcome to the virtual summit stage Dr. Michael Zgoda. Dr. Zgoda is board certified in internal medicine, pulmonary medicine, critical care, and sleep medicine. With a myriad of research, published work, and interventions, Dr. Zgoda spent years discovering and documenting new and innovative ways to treat patients' most advanced care needs. Over those years, he was awarded many times for his diligent work to nourish the industry, nurture patient experience, and advance academic medicine. Dr. Zgoda attended the University of Kentucky in Lexington, where he earned his Bachelor of Science Degree in Microbiology. He attended the University of Kentucky to earn his Medical Doctorate and went on to complete an internship, residency in internal medicine, and fellowship in pulmonary critical care and sleep medicine at the University of Kentucky Chandler Medical Center. He went to Harvard School of Medicine to advance in interventional pulmonary medicine. Later, he attended the University of Massachusetts-Amherst, where he earned his master's in business administration with a focus in healthcare management. Dr. Zgoda has also completed the Executive Leadership for Healthcare professional courses at Cornell University College of Human Ecology and Samuel Curtis Johnson Graduate School of Management at Cornell University in Ithaca, New York. Today, Dr. Zgoda will be sharing his presentation titled Evidence-Based Wellness Program Saves Money, Careers, and Lives. Please join me in welcoming Dr. Michael Zgoda.
Thank you very much. Truly is a pleasure to be here with you all today. As we're about to get into having a discussion of utilizing evidence-based approaches in promoting well-being and professional fulfillment, I just want to thank the team and the selection committee for allowing me to speak and bring to you the data that I'm looking forward to hearing some of your feedback about afterwards. So let's go ahead and just dive in. So evidence-based wellness program, we have found, can actually save money, careers, and even lives. And we will go through each one of these segments individually, first talking about the money, and then careers, and then finally finishing up on how it actually has been shown to save lives. So first, I came into this process just by looking in one department, the Department of Internal Medicine with Dignity Health Medical Group in the Arizona market. Now, at the beginning of all of this, we realized that we actually started to perform some wellness evaluations by looking at a well-being index. So when we wanted to figure out what was going to be our standardized approach that may have some evidence-based component to it, we decided to go with the Stanford model. So we, according to the overall burnout self-assessment, or what we now call the well-being index, it was determined that our current burnout rate, this is specifically at our institution, this is not a global thing, but our current burnout rate at that time for the entire department of over 80 physicians was about 57%. This is according to the Stanford Well-Being Index that we surveyed. Of course, burnout equals a very high risk for attrition. Our provider turnover rate between October 2020 and October 21, again, in the middle of two major COVID surges, was about 13%. Real numbers, about 11 physicians out of 83 care providers left specifically because of burnout. Also, at the same time, aside from our physicians, we also had a lot of staff turnover. So medical assistants, front desk personnel, even nurses in the hospital, respiratory therapists and whatnot. That was about 50% every 6 months we were having turnover. So within 1 year's time, we had completely turned over our entire staff. This is both not good for patient care, but also becomes very expensive. So according to the American Medical Association, they actually put together a calculator that has been validated to look at what is the actual cost of physician burnout for an organization. So by going in and plugging in the numbers I'm showing you now were the numbers that actually came up. These are screenshots of my first sitting down and plugging in these numbers. So out of 83 physicians, we had a 57% burnout with 13% turnover, as I already showed you. Now, when we look at this, looking at all the salaries from my GI doctors all the way down to my primary care physicians, which of course have a different salary structure, it averages to about $475,000 as the cost of turnover in our organization per physician. Now, out of the 13% turnover, I was able to get 4 of those physicians to come clean and say they specifically are leaving medicine because they were, quote, burned out. Now, we're going to be using the term burned out a lot, and I'm going to show you that that's probably not the best term. There's a better way to describe it, but for these contexts and purposes, we'll keep it simple, call it burnout. So I had 4 per year that I was seeing in my very first year of coming on board here. As such, that totals out to about $1.9 million per year. So we decided to go ahead and put together an actual wellness, personal and professional fulfillment program. Again, utilizing the Stanford model to begin with, and then we branched out from there. To help me do so, I went in search of an organizational psychologist, and we became the first department of internal medicine with all of Common Spirit Health, whom I work, to hire our own organizational psychologist. This cost us approximately $120,000 per year. And at the time, we were looking at a projected reduction in burnout of 20%. And I'll show you some real numbers about how this played out and if this was a good return on investment. So again, 4 physicians per year at $1.9 million per year. Estimated savings from the burnout intervention, it was about 8.28% turnover without burnout. So I lost 8% of my physicians' turnover without burnout. That was their claim. So if I could reduce this, the estimated savings due to our reduced burnout would be about $372,000. And if you look at how much it's costing me at $120,000 per year with the utilization of our organizational psychologist and program rollout, that was going to be about a 210% return on investment per year. These are actual numbers. These are the real numbers that we were experiencing. So let's go ahead and narrow this down a little bit to the highest risk group for, quote, burnout. And in my institution was with the intensivists. Our intensivists were overwhelmed. They were very understaffed. We had just opened up a brand new ICU, doubling the number of beds we had in our institution. We had to bring in a lot of travel nurses, as many of you also had to do, to help us just meet the needs of the population. And so we had 11 physicians at the time covering about 80 ICU beds, 24 hours a day, 7 days a week. Now, with this, through the pandemic, where we actually were having patients doubled up, and our average census for these physicians was between 25 to 28 patients per day, we were seeing about an 88% burnout. As such, I started to see some significant turnover at about 18% turnover. And the American Medical Association says that to replace a lost intensivist, it costs about $975,000 per physician. So 18% of 11 is a little over 1 physician, almost 2 physicians per year. So as such, if I just am very conservative and just say, okay, 1 physician per year is going to cost me about $903,000, all things considered, to replace that 1 physician. Very expensive to replace an intensivist, which of course, as already mentioned, has the highest vulnerability. Now, the cost to prevent those burnout interventions within our organization, specifically for intensivists, was about $75,000 a year, we were hoping for a 60% reduction in our burnout rate. So all in all, what we ended up seeing was about a 622% per year return on our investment. So we just poured in about $75,000, and of which we were able to save $900,000. Excellent return on one's investment. So in summary, the overall return of investment for bringing in an organizational psychologist just for the Department of Medicine. This is not for the entire medical group. This was not for the hospital system at large. This was just simply for one department of internal medicine. We saved about $2 million in our first year just doing this. This is by utilizing a organizational psychologist for less than 10 hours per week, or about 400 hours per year in direct physician and staff interactions. So let's talk a little bit about what are these burnout interventions we're talking about. What did we actually use our organizational psychologist for? How did we roll these things out? So first, we decided to use the Stanford model, as you see here. Many of you, I'm sure, have already seen this. Many of you probably have this posterized on your wall and share it frequently. So again, in summary, for those of you who don't, it is a three-legged stool looking to hold up professional fulfillment, including a culture of wellness, the efficiency of practice, and personal resilience. Three different legs of the stool. You lose one leg, the stool collapses. So what we wanted to do was to objectively measure the levels of burnout and among which division within our Department of Medicine was most at risk, which I showed you was our intensivist. So first, we had to choose a standardized well-being index, and as mentioned, we chose the Stanford Well-Being Index. Furthermore, we deployed monthly group sessions for resilience training, and we'll talk about that here near the end of our talk today. And we also did one-on-one personal meetings with our organizational psychologist where we were looking at, quote, pebbles in one's shoe. So what was the thing that was just annoying and grating on our physicians individually in their specific day-to-day work. Lastly, we rolled out something, instead of referring to it as post-traumatic stress disorder, we put together a plan called post-traumatic stress growth plan. So how is it that you can convert from something that was causing people great angst, but instead utilize their post-trauma as a means of personal and individual growth, both internally as well as within our organization? So what we did from the chairman's side of the coin. So the first thing I just showed you was with the organizational psychologist. Now, between the chairman, myself, and the dyad partner in operations, to make sure that we were all on the same page, we had to take a minute, pull back, and make sure that everything that we were doing was in the context of protecting our physicians, as well as our medical staff and ancillary staff. So we have these questions that we would always ask every single person whenever we would have an opportunity to sit down and speak with them. And what we came to the conclusion of is that they all felt these same things, that they wanted to be heard. So they wanted to hear me, protect me, prepare me, support me, care for me, and honor me. This is what people were looking for from their physician and departmental leadership: to be heard, protected, prepared, supported, cared for, and honored. So how did we do that? As you can see, we broke these things down into the different legs of that three-legged stool. So first, the hear me was a part of a culture of wellness. Second, protect me, again, a culture of wellness. For practice efficiency, they were specifically asking for to be prepared and supported. And then for resilience, they were just asking to be both cared for and honored, which is interesting in that all these things that they were specifically asking for have been studied. And without even knowing that, they were laying out the plan upon which we were going to build our program. So let's dive into practice efficiency first. This is the one thing that the department chair and operations can work to very specifically to accomplish this, to really make that leg of the stool solid. So the first thing I chose to do is I put together a team where I chose the top physicians within my department, and I made them, I voluntold them that they would now be vice chairs within the Department of Medicine. These vice chairs were one for quality and safety, one for education, one for innovation, one for research, one for finance, and one for well-being. Now, really what this was is a guise to help us create Physician Leadership Institute. So we created this Physician Leadership Institute. These were the first 6 physicians that were participating in it. And these specific areas of responsibility were the things that they were going to now utilize, because it was through physician leadership that we were able to roll out the rest of our initiative for well-being and professional and personal fulfillment. In lieu of that, we also chose to create a mentorship program. So again, we're looking at practice efficiency. So with practice efficiency, we're looking at the different operational aspects, which you just saw, but now we needed to work on the individual growth for practice efficiency. And by having a mentorship program, this was something that really started to get things and move that needle much more quickly. So we recruited senior physicians to be mentors within our organization, and then we put them through a didactic and personalized mentorship training program with oversight from our organizational psychologist and myself. Once we had established that they were up to speed and how it was and what it was like to be a mentor, then we just went ahead and rolled out our mentorship program, which has really been a success. At first, it was, to be honest, it was hard to get people on board with this because they were busy enough, they were burned out enough, and to them, this was just something new to add. But what we really started to see is that our senior physicians really started to pour into these young doctors. And when we started to see that personal growth among those young doctors, both the senior physicians got rejuvenated by the experience and the relationship, and the young doctors really started to step up into their roles. Another thing we had to do for practice efficiency is we just had to get down to the nuts and bolts of what it was like to have practices in our department. We had to staff up to 1.25 medical assistants per outpatient physician full-time equivalent. So if I have one physician full-time equivalent, then we're going to have 1.25 MAs. We had to extend our onboarding of staff to 2 weeks. So prior to this, because we were having so much turnover, about 50% every 6 months, they were only getting about 2 days of onboarding. This was not enough. This created a ton of dissatisfaction, which escalated the rate at which people were leaving. So what we did is we pulled back on this and just extended our onboarding to an actual 2 weeks of curriculum and oversight before they were let loose with the physicians. This really did help both the physicians and the medical assistants relationships grow to where they got to learn each other in a safe environment where the expectations were minimal. But after those 2 weeks, the medical assistants were ready to go, and it really worked well for us. For our inpatient services, including our hospitalist and our intensivist, we staffed up to 15 shifts per physician per month. So in my department, in my hospitalist service, I have 10 ongoing teams. Each team carries between 15 to 25 patients, depending on acuity. We also have 2 other teams, one specifically for hospitalist surgical services and one for hospitalist oncologic services. So we're seeing upwards of census of about 230 to 250 patients per day with our hospitalist. Now, I needed to staff that up for 24/7 coverage, including nocturnists, and we had to staff up to a way that we were limiting them to only 15, maybe 18 shifts per month. So this is where it was the protect me component of our plan. Furthermore, with our intensivist, we also had to cap them to only about 16 patients per day. So we capped the total number of patients for a hospitalist to 22, and then we capped our intensivist to just 16. At one point in time, I had intensivists seeing upwards of 28 to 30 patients at the peak of COVID. This was too much, and this is why we were afraid of having rapid burnout and then subsequent turnover. Of note, and I put this in here just to give you some perspective, and that is that 75% of our financial and human resources went into this specific leg of the professional fulfillment wheel that I showed you. So out of the 3 different things, I had a budget that I put together. In that budget, 75% of that budget went to practice efficiency. This is the thing that had the most impact. And we realized very early on that we were just going to have to spend the money to accomplish this component of that 3-legged stool. So next on our wheel is personal resilience. Personal resilience in the past has been considered just basically self-care, values, and insight. That was several years ago. This was long before COVID. This is long before we started dealing with the new changes of EMR and value-based purchasing and all the different quality metrics and all the things that physicians are being asked to do now that they were never asked to deal with before. So this is at one point where somebody could be an island unto themselves as long as they took care of themselves, their values aligned with the system, and that they had personal insight to know when and where they needed to take a break. That has since morphed over time. It has evolved into all of these components of those three things, including self-control, also referred to as emotional intelligence, social support. What kind of social support do you have? Family, your own personal optimism. Do you have hope? One's ability to solve problems, back to emotional awareness, self-belief, again, one's own personal value system, and even having the ability to not take things so seriously and actually having a sense of humor. This comes by way of the Mayo Clinic proceedings, is where I have this image from. And in a recent article published by them, is noted down here in the bottom of the slide, they specifically said that it was noted that many things correlate to physician burnout, but systemic contributors that people need to use, or we need to shore up to help with the resilience of oneself, is that there was an increase in workload, panel sizes, electronic medical records, other administrative tasks, chaotic work environment, personal leadership value differences, as well as especially an increased focus on productivity in the context of reduced financial compensation and greater liability threats. Now, I'm sure that these last two are the things that many in leadership have heard the most, especially during the time of COVID when burnout was peaking. And that was the increase in focus on productivity while not getting paid more to work more, being asked to do more, being given more responsibility without being appropriately compensated for that, as well as having greater risks or threats to liability because of the increased workload, such as my intensivist seeing almost 30 patients a day. That makes perfect sense. So when we were stopping and looking at, what is personal resilience? What does that mean? What does that look like? And what we saw was that by looking at the medical literature, we saw that physician-directed interventions have had smaller effects than those actually directed by organizational change. Let me repeat that. This is important. That by focusing specifically on, quote, personal resilience, by putting that into the hands of physician-directed interventions, had very little effect on those directed, but instead was much better in the context of organizational change. You see, there was actually a study that was done that looked at a year-long continuing medical education course. This course targeted specifically on the attention, awareness, and communication skills. And by doing so, this improved physician mood, reduced burnout, and improved attitudes reflective of patient-centered care. What did all that mean? Well, this was looking at, are we going from resilience to recovery? See, now this was a model that was considered and is probably the most recent one that is getting a little more traction, but now is quickly falling away because now that COVID has kind of waned and hopefully we're not going to see another bump over the winter, we're not seeing the recovery like we thought. We thought that as one let's get through this, get them completed to where we can start breaking people out, giving them some time off. That'll give them time to, quote, recover. So recovery was considered a part of resilience. And there is a component to that. Just like in exercise, you need to have time for recovery. And over time, that builds resilience. But you see, when the recovery time is not scheduled, not planned, focused, and does not also include actual work, it doesn't play out as expected. Even professional world-class athletes will tell you that they exercise on their recovery days. People that are training for marathons, I ran a marathon several years ago, and even on my, quote, recovery days, I would still go out and run a slow 3 miles. And that was specifically because recovery does actually require work. So what does that look like now? Well, what we've learned is that personal resilience, and this is really the takeaway from this. So out of all that I've said, this is one of the most important takeaways. Personal resilience is not personal. Personal resilience is actually something that has to be built into our physicians beginning very early on, medical school. Okay. Again, I take this from the Mayo Proceedings article. What we see here is that even before medical school and through medical school, there's a lot of intrapersonal relationships, people helping each other, people helping, they're all going through this quagmire, this nightmare together, this drinking from a fire hydrant. The knowledge transfer is just overwhelming. And in doing so, they come together and they're able to get through that. But then you go into residency, and that starts to wane a little bit because now more and more responsibility is being put onto that individual. Then as you go into fellowship, you're going to have unique responsibilities, unique issues. Somebody does a critical care fellowship compared to a dermatology fellowship is going to have different emotional tasks that they're going to have to work through. Then once you go out to becoming an attending, especially early in one's career, this is when people are most vulnerable to burnout, because all the way up until this point, they have had a safety net of some sort. Now that safety net is gone. And if they have not acquired the tools and the ability and have all three legs of that stool working on their behalf, it's not going to go well. And that is why ongoing wellness needs to be focused on. So let's drop down into some of these lines at the bottom here. So as you can see, additional practices that have to begin all the way back in medical school, including one's cognitive appraisal, reflection, one's physical well-being, and exercise are paramount, and they have to continue all throughout one's career. Then as you go down this list to the very bottom, where you just get to the bottom two arrows, these are the arrows that we as an organization have the opportunity to really affect. Now, in my role as the academic chairman of medicine for the Creighton University School of Medicine, we are rolling things out in the clinical medical school realm. My vice chairman of wellness is actually in charge of wellness for the medical students and helping them get those tools. So it's an actual curriculum-based program to begin this in medical school. Now, the rest of my attendings that I have to help with is in terms of managing teams and groups, as well as a fulfillment and organization. So that last little arrow at the bottom is what this whole talk is about. But keeping in mind that this resilience component, that leg of the stool, is the most difficult, because that is the one that is going to take a lifetime to build strength in. That is why it is not an actual personal resilience component. It is really a team-based sport. It requires a team of people to get around each other as they do in medical school and continue this process all the way throughout one's career. Whenever we started to do some wellness get-togethers, and with our organizational psychologists, we would have resilience training. We had very specific curriculum surrounding our resilience training and whatnot. And in the end, as we got our feedback, because after every single session, we asked for feedback, because we knew that this is kind of a relatively new thing that we were rolling out here, especially as we're rolling out so many things at once. And what we learned the most, the thing that helped our physicians by far and away the most, was just collegial interaction. Doctors getting together, sharing some war stories, sharing their burdens amongst each other, basically one beggar telling another beggar where to find bread. And that is what gave them the strength to continue to press on. Those that did that, for us offering those opportunities for them to do that, helped more than anything else that we did. So again, personal resilience is not personal. It really is a team-based sport. So we're going to wind this down. I'm going to share with you again, we talked about money, we talked about careers, and we talked about how this evidence-based approach can save lives. So again, as mentioned, 623% actual return on investment just for my intensivist. This does not include the hospitalist or any of my outpatient physicians. I'm going to bore you with these numbers, but this is obviously the biggest number, so I'm going to show you that one. But that being said, you can actually see the math here, that this is pretty basic and straightforward stuff that you can use at your organization to try and do the things that we've done. Staff turnover. So this is not the physicians, this is staff. Actually 719% actual return on investment. These are real numbers. These are not fudged. These are just plain old numbers, ratios, and whatnot. So we went from 50% turnover in 6 months to less than 10% turnover. That saved us about $413,000, which turns out to be about 720% actual return on investment. Careers. So when we look at our older physicians that were ready to leave the organization, they were winding down their careers anyways. They had been there and done that. COVID was taking its toll. They were being asked to do things they had never been asked to do before. They came to me and they have shared with me that it was very specifically our focus on one's professional fulfillment, well-being, practice efficiency, and personal resilience that kept them in practice. We do not want to have a loss of this brain trust. The experience, the stability, these physicians are the rudder that kept us stable in a time of turmoil. And as such, keeping them as long as we can and allowing that knowledge transfer to occur to the up and coming generation was imperative. We did not want to have a brain drain on our department. And fortunately, this appears, at least at this point, to have worked. These physicians are very, very happy, and they're very excited to continue to remain with us. So the program has now saved careers. Let's talk about lives. And this will be the last thing I'm going to close with. It's going to sound a little dark, but then we'll finish with a line of hope. So as you know, COVID-19 had an increased risk of physician suicide. This has been published on multiple articles, and they were blaming it on the medical system, not on the circumstances, but on the system surrounding this. This comes out of Cornell. Medscape put together a 2022, I think they entitled it Tragedy of the Profession. The tragedy of the profession. It was the Medscape Physicians Suicide Survey for 2022. What they saw was that there was a type of depression among physicians, of the different types of depression, clinical depression, including severe depression, lasting quite some time, that's not caused by, say, normal grief of loss of a loved one or whatnot. 24%, 1 out of every 4 physicians that you saw were clinically depressed. 64, more than half, had a clinical depression of just feeling down, blue, and sad all the time. Less than 11% of people, less than 11% of physicians just felt like their normal selves. Then when asked, have you ever felt suicidal or attempted suicide? 85% said no. But the thing that was most impressive to me was that 10% said yes. And of those 10%, 1% of those overall, so 10% of the 10%, have actually attempted suicide. So 1 out of 100 physicians that you see out there in your department, in your institution, has at one point in time in their life attempted suicide. When asked, have you ever felt suicidal or attempted suicide, when looking at the difference between men and women, you can see that actually women feel it more than the men do. Women feel it more than the men do. In terms of attempts, it's equal, but women are really coming along with, they're carrying more of a burden, probably because, and it's assumed that they're carrying not only more of a burden at work, but also at home. So they're still asked to maintain the social mores and societal, the societal demands that are put on women, as well as having to go to work and be a physician and to handle all the stuff there. So that added stress on women over men in this circumstance does appear to be playing itself out, upwards in 2% increase over men in terms of having suicidal ideations. And then when you're looking at the generational component, are we looking at people over the age of 57, referred to as boomers? Then you have Generation X, people that grew up in the 80s and 90s, early 2000s. And then finally, the millennials, ranging between 27 and 41 years old. Most of your physicians are going to be in their 30s, as they've all sacrificed their 20s on the altar of medicine to try to get into the profession in the first place. So when you look at this, you can definitely see a difference between a generational understanding and recognition of mental health in and around physician suicide. Millennials believe more so, and you'll see here in just a second, that it is an institution's responsibility. As you get older, you'll see that Generation X and that the boomers feel that as though it is less responsible for the institution. But also what you notice is that the millennial generation tends to focus a lot more on friends, colleagues, and therapy, but more so than anyone else on family when it comes to having thoughts of suicidal ideation and how to work through that. So your millennial generation is going to need to have more familial exposure to their families to help get through the difficult times, more so than, say, boomers or Generation X type generation. So why is it that physicians keep their suicidal thoughts secret? These are actual statements. I'll just jump down to the second one for the sake of time. Physicians cannot seek help for these issues because if we do that, these temporary issues will follow us for the rest of our careers. As I went through credentialing and I was helping one of my physicians go through credentialing, there was multiple questions on there about if they've been on medication for depression, have they ever attempted suicide? Questions I thought were almost a HIPAA violation in terms of asking somebody for their medical history. Nevertheless, we're starting to see these things come out in terms of credentialing. Why? Well, because we're seeing more and more physicians have issues with this. I don't think it's going to be used as a tool to keep from hiring somebody. I think it's going to be used as a tool to help provide for physicians and to give them the tools and structure they need to be successful. Another perception is that they're afraid that if they spoke to a therapist, they'd have to report it. They have to report as though they're receiving psychiatric treatment, share that with credentialing and the licensing board. And again, this would follow them. You see, talking to someone makes you look like a failure and that you're unable to cope with one's own life problems. This is not the thing that they want to follow them. When asked if any of their colleagues or other physicians ever told them that they were having suicidal thoughts, 13% of women and 10% of male physicians have said that somebody has told them that they were having suicidal thoughts. Of those, 79 to 81%, about equal between men and women, they tried to help them by speaking with them. The majority actually tried to get them recommended that they would get some professional help. And the rest just spoke with family members and whatnot. But you can see there's a huge difference between just you hear, okay, my colleague is having suicidal ideation. So you talk to them, you recommend they get some professional help. Rarely do we tell them to speak to their family members, which is interesting because that is where the millennial generation is going to get their most benefit, according to the research. So as I mentioned earlier, should institutions be held accountable for maybe physicians or medical students that hurt themselves? The millennial generation believes, yes, that you should, 31%. Typically, they're 30% across the board. 31 said yes, 33 said no, and 37 said, I'm not sure. However, when you start to move up in age for physicians, only 19% said yes. For the Generation X, half of them said no. And then when you look at the boomers, only 12 of them said that the institution should be held accountable or responsible for any students that might hurt themselves. And 60% said absolutely not, said no. So perceptions towards mental health, you can see in the older generations is not as understood or appreciated as much as it is in the younger generation. So this is something where my younger physician leaders are now teaching my older physicians the importance of mental health surrounding one's own personal resilience. So when asked, and I'll close with this, when asked, how are you keeping up with your own happiness and mental health? 68% friends and family. You have to give your physician time with friends and family and time to do the things that they enjoy outside of work. And again, one other thing that is very important is exercise. Having physical activity has been shown to have just the benefits are, the list is longer than you can imagine in terms of the benefits of exercising. Exercise and sleep. these are the things. Now, one thing that is interesting on this, about 44% of people said that they choose to eat healthy for their mental health, which means that about 66% of people emotionally eat. And who knows what we all eat when we emotionally eat. But that can become an issue because then that makes you not want to exercise, makes you not want to do the activities that you enjoy. And a lot of people feel guilty about how they emotionally eat, so they won't spend time with friends or family because they put on some weight and they don't want to be judged. So, there's a lot going on here when it comes to this component of personal resilience. Now, I wanted to finish up with saving lives. So we use the well-being index, and we continue to roll this well-being index out at least quarterly. And with our well-being index, we were able to red flag 2 physicians that were very, very high risk for suicide, and one of which actually had a plan. And we were able to jump in and have an immediate intervention. We paused their clinical practice completely. We did not pause paying them or anything we did not want to burden them with that. We had to support them. We had to care for them. We had to do those things they asked for, which is to hear me, prepare me, protect me, support me, care for me, and honor me. We got them immediate psychological and psychiatric help. And actually now they're back to full-time practice. And now they are my biggest advocates for helping other young doctors whenever they see people stumbling or having difficulty or acting out in a certain way. So not only were we able to, what I believe, save physicians' lives, but now maybe even more will be touched because these physicians are now champions in this component. So today we talked about how rolling out a evidence-based program, which as you can see is broad and deep, is able to save money, save careers, and save lives. This was not expensive. This just took commitment and effort. And it's going to take support from your overall organizational leadership. But in doing so, you will be able to see an impact on multiple levels. And at one time when people felt anxious when they had to get up the next morning to come into work, now they're going to want to get to work. They're going to want to be here because this is now a safe place where well-being is prioritized. Thank you very much for your time, and I'm open to any questions you might have.